To all of you. Once again, welcome to Department of Urology, Savai Mansingh Medical College, Jaipur. Today's teaching class subject is step-by-step approach of URSL and its applied anatomy. And this will be delivered by our resident, Dr. Pankaj Chaudhary, and will be moderated by our faculty, Dr. Ajayraj Singh. So I would request Pankaj to kindly share his presentation and go ahead. Make it full screen, yes. Try to make it full screen.
Good morning, respected teachers and my dear colleague.
Make it full screen. Full screen, please. Sayam, help him.
It is showing full screen here.
No, it's not showing full screen. Go ahead.
Now full screen, sir?
No. Yes. Yes, go ahead.
Today's topic of seminar is surgical anatomy of URSL and step-by-step approach. First, anatomy. Length of ureter is around 22 to 30 centimeter, and in units it is 6.5 to 7 centimeter long, and diameter is 1.5 to 6 mm. And it is divided into proximal upper and middle over the sacrum. Distal is a lower segment. Surface anatomy, a line joining a 0.5 centimeter lateral to the L1 spinous process and the posterior superior iliac spine. Water under the bridge. Ureter is below the gonadal vessel and ureter is below uterine vessel in the pelvic region. In the vaginal surgery, left ureter injury more because left ureter crosses the anterior fornix more close. Endoscopic anatomy, the intrauterine ridge, the Mercier bar is more prominent in male than female. Trigone is the most vascular part of the bladder and is formed by an extension of the longitudinal muscle fiber of the ureter over the detrusal muscle. Normal ureteric orifice may appear as a cone or a volcano. Grade 1 stadium is called stadium, and grade 2 horseshoe, and 3 is called whole ureteric orifice. Location of ureter is medial. This is the medial aspect of the trigone, which is called position A. And higher the grade and the lateral the location, reflux is more. For flexible ureteroscope to pass from the axis of the upper ureteral segment to the axis of the lower infundibulum, it should be deflected 140 degrees at the uretero-infundibular angle. Rigid ureteroscopy. In rigid ureteroscopy, ureter forces anterolaterally as it goes along the lateral pelvic wall. Then it crosses the pelvic brim. It angulates posteriorly to continue as the proximal ureter. Now the pre-treatment assessment for the URSL. First, the stone factor, location of the stone, proximal mid versus distal, and the stone burden 97% success for less than 1 centimeter stone and 93% success for more than 1 centimeter stone. Stone composition doesn't affect the success of the procedure. The anatomical factors, if there is megaureter, endoureterotomy is done in less than 3 centimeter segment, and then URSL is done. Duplicated collecting system, in duplicated collective system, first RGP is done, and then URSL is done. In ureteral stricture or stenosis, first dilatation is done, and then endoureterotomy is done. Now the patient factor. First, the patient should not have any UTI, so negative culture should be obtained before the procedure. And the renal function, if the in symptomatic upper tract and less than 15% split function, an nephrectomy can be considered. In solitary kidney, even asymptomatic stones are treated. Morbid morbidity. In morbid morbidity, URSL success and safety independent of BMI is there. Spine deformity and in spine deformity and limb contracture, flexible URSL is used. In the cases of coagulopathy, URSL plus Hoya lithotripsy is the treatment of the choice. Duration of obstructing ureter stone is if it is more than for the 4 week, it should be treated first. Patient and equipment positioning. Lithotomy position with liberal padding and flexible URSL is visible in supine and also in lateral decubitus position. Tables should be radiolucent. Fluoroscopy, first fluoroscopy is done. Fixed in all in one table and portable C-arm unit. 2 irrigation bags are used. First one is under gravity and other one is pressure bag. Laser consume is as close as to surgeon as possible. Surgeon can sit or stand. Different instrument, cystoscope, rigid cystoscope and flexible cystoscope are used. Ureteral access is done by Guidewire, which can be PTFE, that is polytetrafluoroethylene coated, hydrophilic coated, hybrid wires, which is having hydrophilic tip and PTFE coating with the nitinol core. And it is available in various stiffness and it may be angled or straight tip. Ureteral catheters, it may be straight or angled. Ureteral dilators, sequential serial dilators, and balloon dilator, which is helpful in like strictures of ureter. Ureteral access sheaths comes in various length and various diameters. Ureteroscopes are available in semi-rigid ureteroscope, which can be offset eyepiece, direct vision eyepiece, various length, various number and size of working channels. Flexible ureteroscope in which fiber optic or which may be fiber optic or digital and comes in various diameters. Intercorporeal lithotripters, vulvar yak laser, pneumatic lithotripter, and electrohydraulic tripter. Basket and stone retrieval device may be baskets which may be nitinol as a material or stainless steel. Graspers and graspers. Ureteral occluding devices, anti-retropulsion devices, and post-operative ureteral stents are there. Guidewires are guide to access, dilatation, and stent placement. Diameter ranges from 0.018 to 0.038 inches, and most commonly 0.038 inches used. Length 80 to 260 centimeter are available, and the most common is 145 centimeter. Distal tip may be straight, angle, J-tip, or floppy for 13 centimeter. Nitinol core wire are kink resistant and stripper. Glide wires which are hydrophilic coated wires should be used. Hybrid guide wire, hydrophilic tip, and PTFE shaft. Ureteral catheters. Length is usually 70 centimeter with marking at every 5 centimeter. Straight tip catheter, 5 or 6 French are available. Dilatation devices, passive dilatation, pre-stenting for more than 7 days before URSL is done. Active dilatation, dilating catheters, hydrophilic coated polyurethane tapered catheters are available. Balloon dilators are available filled with diluted radio contrast. Ureteral access sheath, placed over guide wire under guidance. It helps in flexible URSL. It is useful for repeated entries, stone fragment retrieval, decrease renal perfusion pressure, and increase irrigation flow, which improve vision. Inner dilator and outer sheath is there. Ureteroscope, semi-rigid ureteroscope. Larger working channels are present and they are less prone to damage. Length short in female and long in males. Tip diameter is less than 7 French. Eyepiece inline offset. Straight working channel in offset. Working channel may be single or double. They are easy to reach till ureter cross the iliac vessels. Parts of the semi-rigid ureteroscope: shaft, light pillars, eyepiece, and inlet and outlet tops, and working channels. Types of eyepiece: direct view eyepiece, that is straight, Marburger type eyepiece, angled offset, and the Bichler type eyepiece is oblique. Flexible ureteroscope. Types of flexible ureteroscope: fiber optic bundle carry the light and images displayed on the screen. In digital one, chip on tip is there, which shows digital image. Deflection mechanism: plane of deflection marked by a scope rotated to align the plane of deflection with the intended target. Intuitive or counterintuitive deflection with respect to lever is there. Deflection more than 180 degrees achieved in this. Intracorporeal lithotripters, pneumatic lithotripters, which are required in semi-rigid Usrl with a straight working channel, that is offset eyepiece. Retropulsion is there, but in this in pneumatic, retropulsion is there. Electrohydral lithotripter, flexible, they are flexible, but more damage is done by electrohydral lithotripter. OEG lasers, intraluminal lithotripsy is an energy of choice. Testing of stone is by photothermal effect. Stone retrieval devices. Safest one is the 3-pronged stone grasping faucet. Stone baskets are also available, which are helical basket or that may be flat wire basket. Surgeons should be able to see the endoscope, stone and urate during the extraction. Nitinol alloy baskets are also there, which have the body, which maintains shape and are also resist thinking. Retropulsion prevention devices. They prevent migration of distal ureter stone in semi-rigid Usrl into proximal ureter. Stone migration devices are designed to stone retropulsion during lithotripsy. Entrap ureteral occluding device, stone cone, and the escape basket. The accordion ureteral occlusion device is shown is here is a nitinol and polyurethane film combination that is applied above the stone and then accordion to occlude the ureter to prevent stone and fragment retropulsion. Ureteral stents are used for drainage. Double J stents. Routine stenting has no beneficial effect on stone-free rate or ureteral stricture rates. Quality of life is better in non-stented patient. Indwelling time less than 14 days. Fewer adverse effect. Placing stent for 1 to 2 weeks after initial successful Usrl leads to higher success rate of secondary Usrl. Ureteroscopy for lower ureteral stone, just below iliac vessel. First step is rigid cystoscopy. Then guidewire is inserted. Cannulation into ureteric orifice is done, and RGP is done. RGP is the map of stone location and map of stone location, collecting system anatomy, potential pitfall that may encounter during ureteroscopy. Safety wire are used. Open end 5-trench catheter pass up to kidney under fluoroscopy. Hydrophilic guide wire is used. It should be never forced because it may lead to mucosal perforation. If virulent pus is there, stent should be placed and procedure should be avoided. Culture and sensitivity of the pus should be sent. Before doing ureteroscopy, bladder should be empty always. Ureteral calculi below iliac vessels are best treated by semi-rigid, which helps in more irrigation. Visualization is better and has also large working channel. Ureteral orifice, if ureteral orifice is narrow, second guide wire over semi-rigid ureteroscope and is placed and inserted into the ureter, which is called train tracking technique. If it is unsuccessful, dilatation under fluoroscopy is done by using balloon, ureteral dilating sheath, and cerium ureteral dilators. You should not do dilatation over stone because it may lead to ureteral trauma and complete exclusion. Ureteral stents. Passive ureteral dilatation is done and stent and done and the attempt is made after 1 day, which has high success rate case to a complicated one. Entrapment devices are used. Bladder is drained intermittently, which avoid overdistension lowers intraureteral pressure and intracorporeal lithotripsy. OEAG laser is the most efficacious and safe and first line in the first line of management. Pneumatic, ballistic, and ultrasonic and electrohydraulic lithotripsy is used. How to increase visualization? Continuous controlled high pressure irrigation less than 1200 mmHg with the automatic irrigation devices is used, and palm NS fluid is preferable, and the smallest instrument preserves the flow of the irrigation. Laser settings are based on appearance of stone. If the stone is soft, 0.2 joules in 50 Hz is used, and painting and dusting is done. If the stone is hard, lowest setting 0.6 joule and 6 Hz is used, which is increased gradually. When basketing is done, always under vision, it is always done under vision, and you should grasp the leading fragment only. Complete treatment is done, and the tract is again inspected. RGP is done to check any undetected injuries there or not. Stentless ureteroscopy is done in uncomplicated and low risk patient, and a good cull is obtained in kidney and bladder. Ureteroscopy for upper ureteral stone above iliac vessel. Stone higher in proximal and ureter. Excess sheath can be used. Excess sheath helps in improved irrigation, visualization, continuous drainage, decrease intrauterine pressure, decrease intrapelvic pressure, passage and repassage of flexible ureteroscope, decrease mechanical deterioration of the instrument, and the sheath should not be placed over stone, which may lead to trauma and extrusion of the stone. Basic principle is same. Complete extraction is done, and thorough inspection is done after the extraction, and RGP is done at the end. Shown here the placement of a ureteroscope. Visualization of the stone during ureteroscopy. And here it's shown fragmentation of stone for complete basket extraction, but there is a risk for ureteral avulsion during basketing. Here it's shown excess sheath stones that are high in the proximal ureter may be more easily accessed with an excess sheath. Step-by-step procedure in Usrl. Pass the ureteric catheter up to the calculus. Inject contrast via ureteric catheter to study caliber of ureter below and above the calculus. Pass a 0.035 floppy tip guide wire by the side of calculus. Position the wire to pelvic helicity system. Withdraw the ureteric catheter and leave the guide wire in situ. Withdraw the ureteric catheter and leave the guide wire in situ. Withdraw the lens and let the 22 French sheath and wire stay in. Pass 6 French ureteric dilator over the wire to start dilating the orifice and the intramural ureter. Pass 12 French dilator and engage its tip in ureteric orifice. Remove cystoscopic sheath and leave dilator in situ. Fill the urethra with lubricating gel. Remove the dilator and the urethral sheath and wire stays in. Use 8 French rigid ureteroscope attached with bulb irrigator for pulsatile increase in flow. Pass ureteroscope through urethral sheath. Use hydrodilatation to facilitate entry into ureteric orifice. Pulsatile flow from bulb irrigator improves visibility. Disintegrate the calculus by pneumatic devices. Use a triprong pulsar, which is the safest method to pick up the stone fragment. Keep bladder end of urethral stent close to ureteric orifice. The urethral sheath protects urethral mucosa from abrasive injury by rough stone fragments. The urethral sheath allows quick transition through the urethra. The urethral sheath is light in weight and does not hamper with ureteroscopic maneuvering. Use clockwise and anti-clockwise rotational movement on the crasswell to avoid catching the mucosa. Big fragments can be taken out quickly through the sheath, through the sheath, and the irrigation should continuously flow out of urethral sheath, keeping bladder decompressed. The low intravesical pressure makes entry of ureteroscope into ureter easy and quick. The urethral sheath directs the operator straight away to the ureteric orifice and the final look into the ureteric lumen after stone removal is done. 5 French descent or guide wire through the urethral sheath is passed. Sheath allows passage of guide wire and ensure correct placement of renal end of the descent under fluoroscopy. And the urethral sheath is removed. Now, the complication of the ureteroscopy perforation, which is seen in 0 to 4% of cases, it is due to splitting after the balloon dilatation, forceful placement of ureteral access sheath, placing dilator access sheath over stone, and giving forceful pulling of basket devices, and the direct injury by the lithotrides. It is highest with the electrohydraulic lithotripter. Pressurized irrigation, perforation, and calcium rupture is there. If there is a rupture, perforation, abandon the procedure, and the stent is placed over safety guide wire. Stricture is seen in 3 to 6%, which is due to impacted stone, and the ureteral perforation is in ureteral perforation cases 6% stricture rate is seen. It may be due to prior ureteral surgery, previous ureteral surgery, or the patient has undergone any pelvic radiation, and 0.04% are asymptomatic. And the recommendation for all patients to undergo post-operative imaging after ureteroscopic instrumentation. Stone extrusion is seen in 2%, and submucosal. If the stone is submucosal, laser excision can be done, and a ureteral stent can be placed. If there is a complete extrusion or a lost stone in ureteral perforation, procedure should be abandoned and a stent is placed, and there should not be any attempt to retrieve the stone. Avulsion is seen in 0.06 to 0.5% of cases, and it is due to forceful manipulation of large impacted stone. And avulsion while you are trying the scope, avulsion due to scope at all, which is called Scavard effect. Yes.
In the meantime, we have some problem with the video. Let's see whether we are able to play it or not. I would request any of the residents, faculty, anybody has any suggestion, idea, or query, please go ahead. I mean, when we talk about ureteroscopy and URSL, lithotripsy, etc., I think few things need to be noted, I think. I mean, number one, as you talk about the ureteral dilatation, most of us probably do not do ureteral dilatation anymore. With the miniaturization of the ureteroscope and scopes 4.5 French, 6 French, usually they do not require ureteral dilatation. So it's a very rare circumstances you do a ureteric dilatation for ureteral URS. Secondly, he talked about basket. Basketing is probably almost obsolete. It's a dangerous instrument, and never try to hold any large fragment in the basket and try to retrieve it. Because, as you know, it can cause major injury to the ureter, it can cause allergy also.
And it may be very difficult to remove the basket from the stone. The basket doesn't come out of the orifice. So these, I think, two things are very important. And then another thing about laser lithotripsy, particularly compared to thulium laser coming and so many people doing thulium lithotripsy, chances of developing ureteric stricture have definitely grown very high. So we have seen ourselves that we have done so many cases of ureteroplasty, which was never seen, I think, in our days, maybe 10, 20 years back. And even I think 10 years back, there was no such high incidence of ureteric strictures, which has grown so high. So just for a small stone, you are making this patient almost a lifelong problem of ureteric stricture, because whatever you do, you would not be able to replace the native ureter. So it's very important that when we do laser lithotripsy, has to be done very, very meticulously and very with all kinds of safety measures. So what happens is, in my personal opinion, if you have a very large stone, impacted stone, particularly more than 1 centimeter impacted stone, I still feel that doing a lab ureteral fracotomy or lab ureteral fracotomy, I don't have lab, even an open ureteral fracotomy or large ureteric stones, is much kinder to the patient. It may be slightly more morbid, definitely, but it's kinder to the patient and you are avoiding complication, a major complication. So still, I think lab ureteral fracotomy also. So we have the video. I request Pankaj to go ahead.
Here a video of Usrl is shown. 53-year-old female undergoing Usrl. First, cystoscope is inserted and the cannulation is done. And Guidewires placed.
I think we are next
The stone is located. Here the dusting of the stone is done. Thank you.
So any of you has any question, just let me know. And we have any of the faculty members, Dr. Anurag Yadav with us. Dr. Anurag, Dr. Baleshwar, and Dr. Kim is there with us. So any of you, if you would like to join us and give your opinion regarding URSL, you are most welcome. Dr. Kim, Dr. Anurag, Dr. Baleshwar. And any of our faculty, Dr. Neeraj, Sanjay, Nachket. So in the meantime, residents, do you have any query regarding URSL? Ureteral. Okay. So ureteral axis sheath, as he said, proximal ureteric stones. The stones which are above the iliac vessels, sometimes it's difficult to negotiate the rigid ureteroscope, and you have to take this flexible ureteroscope, right? So flexible ureteroscope, it's always better to have a ureteral access sheath. So people are doing even without ureteral access sheath. So it depends upon surgeon's preference, and there are advantages and disadvantages of putting a ureteral access sheath. Sometimes you cannot put a ureteral access sheath without dilatation. So you have to dilate and put it. So not necessarily in every patient, but yes, there are specific indications where it is you are better off with putting a ureteral access sheath. One thing that he was stressing upon is the ureteral sheath. So ureteral sheath is also a good thing, particularly in URSL, where you have to remove the ureteroscope maybe 1, 2, 3 times. And it's always easy to negotiate the ureteroscope with the ureteral sheath. And when putting a DJ stent is also, I think, better with when you have a ureteral sheath inside. So I think this is a good kind of addition to our whole armamentarium of doing a ureteroscopy. Anything else? Exactly, what I said. So most of us would not dilate the ureteric orifice because we have so small ureteroscopes available now, even 4.5 and 6, which probably in most of the cases do not require any dilatation. Only in specific cases we would require dilatation. Very small. Personally, I think we have almost not doing any ureteric dilatation. Anybody? Yes. See, if it is lying just below the BOJ, then you might do PCNL. So in that case, you have to push the stone up in the pelvis and then do a PCNL. Particularly when the stone is large. I think if there's a large stone, it's better and easy to do a PCNL than a URSL. And secondly, inadvertent pushing of the stone into the pelvis. Sometimes when you try fragmenting, the stone goes up into the pelvis, then you have 2 options: either do a RIRS in that patient or do a PCNL. So inadvertent pushing of the stone into the system, or kind of purposely pushing it to do a PCNL. Both the ways, I think it is depends upon the surgeon whether you want to do a PCNL or go ahead with RIRS. Anybody else? Yes. Yes. So in by just a preliminary imaging study, you can guess whether this stone is impacted stone, because most of the impacted stone, large stones, will have kind of a moderate to severe dilatation of the system and the upper ureter also. So in that case, you may go ahead and take a decision that yes, you would like to do a ureteral lithotomy either by lab, or if you don't have facilities, even by open. I think still it is a feasible option. It's a valid option. Considering the development of ureteric strictures, so many ureteric strictures after doing a lithotripsy of large ureteric stones. So if you have taken a decision to do a URSL, then if you are not able to pass a guide wire, suppose up the stone, or you're not able to maybe because always putting a guide wire beyond the stone would be a very safe thing to do in fragmenting this stone. So I think if it's not possible to pass a guide wire and it's a large stone, you can take the decision of doing a ureteral lithotomy rather than going ahead with a blind kind of a URSL lithotripsy. Okay, so thank you once again. And if anybody doesn't have any other question, I would thank all the participants, faculty, residents, and those who have joined us today for this presentation. And have a good day. Thank you.